Hello everybody. Are you listening me? Please reply me on the chat box. Assalamu alaikum. Today we are going to discuss very important topic as this is scheduled for by Professor Dr. Muzammil. But today he has some urgent meeting, so he is not attending today lectures, and I am going to deliver this lecture to you. This is a paradoxia of unknown origin, and in some extent it is a very important topic in infection unit. So as you can't Google, you can't diagnose a patient until you have a thorough knowledge of all the infections. And even if a patient with fever approximately of 4 weeks, and you are unable to diagnose which sort of fever is this, then real medicine which you is come in, and you can't Google pyroxia of unknown origin, its diagnosis, labs, or its treatment. Other than infection such as you enteric fever, you want to see the list of, you just Google and you see the list of investigations or management option. But in such a case of pyroxia of unknown origin, you can't Google. If you Google, you show Google show up approximately 100 of investigating tests and approximately 50 treatment options. So this is a very important topic. In this extent, you have thorough knowledge of all the infections, and then to apply and then make a diagnosis. If you are unable to make a diagnosis, then you label this patient is a pyroxia of unknown origin. As such, pyroxia of unknown origin is never your first diagnosis. Even if a patient have a history of fever from 3 weeks or more 4 weeks, but you don't label this patient have a pyroxia of unknown origin until otherwise you can't be able to diagnose with the extensive investigation options you have. Then you label at the end this patient have a pyroxia of unknown origin. So in exam or in clinical classes, never write a patient with a fever history of 4 weeks. You first write a pyroxia of unknown origin is your first diagnosis. If you throw this diagnosis on the face of the examiner, is our first diagnosis is my first diagnosis pyroxia of unknown origin. So by definition, pyroxia of unknown origin is fever of fever of 38.0 Celsius on multiple occasions for more than a week, more than a four-week history, despite initial investigation in hospital for 1 week. So you label this diagnosis even when the patient have a history of approximately 3-week history of fever, and you do extensive investigation in 1 week, then you label this patient have a pyroxia of unknown origin. This is a pie chart presentation of important causes of pyroxia of unknown origin. As you see, the first important is approximately 50% of your causes are infective causes, and then comes is 11% causes is always remain unidentified. Instead of all the extensive investigations you want to carry, but still 11% causes you can't be able to the reason of pyroxia of 24% is in the territory of connective tissue disorders like SLE, rheumatoid arthritis, polymyositis, dermatomyositis, systemic sclerosis. This is all connective tissue disorder and the second most common cause of pyroxia of annular region. Others are 7% is around what are neoplastic causes, and other 8% comes in the other causes such as any sort of periodic fevers or viral infections and familial causes. These are all the causes of which come in the territory of which we will discuss in later on. No, this is important. First, we are going to see the which are the important causes of infections. Which is, number one is liver abscess, pancreatic abscess, hepatitis, and biliary infections. Other are polio, pyelonephritis. I concise this in a table. Table. Let me show you. This is yeah. This is number one is I classify this in two lists. First is abscesses, and second is itis. Abscess is more is liver, pancreatic, pelvic, brain. Abscesses, soft tissue, tubo-ovarian abscesses. So you classify these infections in two big categories. One are abscesses and other are itis, inflammations anywhere in the body. In second part is itis is hepatitis, infective endocarditis, vasculitis, biliary infections, pyelonephritis, osteomyelitis, necrotizing fasciitis, and cystitis, diverticulitis, all comes in the cell. Under this territory is itis, which I make this table for you, and hopefully it's very helpful for you. So, to go, it's all the same. Other are some rare causes which we for come in the territory of other infections or other causes, which are the periodic fever syndromes, and other are some family history, which is very important for this periodic fever syndrome, which we discuss later on. There is one point for children and young adults. They have always, when you see a patient with more than 3 week history and you go for extensive investigations, but you can't find the cause of the fever, always think about in children, think about the viral infections is the number one cause for PUO. So in PUO is a patient with PUO most important for make a diagnosis or a cause of the PUO is always a stale history and examination, which you do daily in the ward. Practice is daily. For example, patient come in admitted in the medical ward, and it's not only one time you take history and daily you come and do a vital sign or no. In cases of PUO, always make a habit of take a daily history and do a daily general physical examination and detailed examination. You always approximately 70% in my experience, 70% of causes of PUO, you find a clue where you go for a diagnosis. Yeah, in investigation, in examination, you go for rashes, sign of infective, you go listen a murmur over there, feature of vasculitis, any purpura, any sort of conjunctivitis, joint inflammation. In men, the prostate should be considered as a potential source of infection. So this is prostate is always prostatitis men is common at a tree where you easily forget to investigate a prostatitis. We go for other investigations, chest X-ray, CT, MRI, but we forget about it. Here we discuss uh, the less important causes or less investigation you do in your routine examination. Clinician should be alert to be possible causes of fictitious fever in which high temperature coding are important. So here is come the infections. First, these are the few early point of infection we are going to discuss. Specific equation. Abscesses, or as I told, abscesses in the liver, pancreas, in the biliary tract, pulmonary abscesses, CNS abscess, intra-abdominal, diverticular, urinary tract, any intra-abdominal organ can have an abscess, and it's easily you can be it's not easy to diagnose a case of intra-abdominal abscess. Infections of oral cavity. Another important aspect the patient may have a dead infected tooth and have a spike of fever. You do an extensive investigation of everything, but you can't find the exact cause. So always examine our oral cavity if a patient have a prolonged history of fever, and then listen. Every clinician, every physician must, in my experience, always listen heart and lungs. If you do a private practice in later on or in big setting hospitals, always a physician, always listen heart and lung. This is always very helpful. I am giving you a clinical or a pearl for this. I think it's a golden pearl. Specific examine or specific organism which comes in the mind of when you see this think about a patient of a PUO. Some bugs come into your mind, which are number one is TB. In our population, TB is very common and always very difficult for us to diagnose. We can easily diagnose a case of tuberculosis, but extrapulmonary TB, make a diagnosis of it is always challenging for us. HIV infections. Nowadays, in Pakistan, HIV patients are increasing. Other viral infections, cytomegalovirus and Epstein-Barr infections. These are the few facts which will come in your mind when you see a patient of PUO. Number one is TB, HIV, and other viral infections. These are very lethal viral infections, cytomegalo and Epstein-Barr virus. In a few other organisms such as fungal infections, Aspergillus species, Candida, and dimorphic fungi, they are come in the list of fungus infections. And then other rare infections such as Treponema vipli, Bartonella hensley species, these are also rare infections. Then in history, always take a travel history. Okay? These are the few causes which come in the specific geographic. If patient have a travel history of such as Africa, Asia, you think this patient may have a malaria, dengue, liquid cell infection, brucellosis, or amoebiasis. liver may be assessed, gut may be assessed, and so in Pakistan or in Asia, enteric fever is no pandemic here. In southern Europe, leishmaniasis species are very common. And, there are many causes of many types of leishmaniasis. Visceral leishmaniasis, patient have a visceral manifestation of cutaneous leishmaniasis, which is common in American, some part of America. The leishmaniasis is all very common there. And then Southeast Asia, in such as patient travel to Thailand or Singapore and Malaysia, Porphyritis pseudomonale is a very common bug there, which causes pneumonia-like illness and may involve a multiple organ as well. Arabian countries, Middle East respiratory syndrome. As you know, there's a pandemic of which see as a Mars syndrome. You listen about it, Mars syndrome, which is causes influenza-like illness in Arabia, Arab countries, and its pandemic is over there approximately in 10 year back. Same presentation as a coronavirus. In some residents or in travel to a region which have a patient with is travel to Africa, Asia, Central and South American. TB is a very common mycobacterium is a very common organism. You got easily infected with tuberculosis. And in Asian countries, we have see an extensive drug-resistant TB. The patient have a history of brucellosis species are very common in Africans, not in Pakistan. Pakistan, but in Afghanistan, areas with Pakistani area with Afghanistan border area, and in Afghanistan, cases you see cases of brucellosis over there. There is a common present even. Some migrant from border area of Afghanistan travel to Islamabad. You will see patient of brucellosis in these areas. So brucellosis have a same approximately same manifestation of tuberculosis, except bone pains or phalgias are very severe in cases of brucellosis. HIV infections. Africans are notorious for HIV infections. And Central and South Africa, there's so many cases of trypanosomiasis, which has very lot of type of trypanosomiasis over there. If patient is admitted in the hospital, you think about nosocomial infections, and easily a patient can have a pneumonia. Of nosocomial infections, bugs are always resistant to basic antibiotics, and we have to go for very broad spectrum antibiotics for treatment of nosocomial infections. Pneumonias, ventilator associated infections, surgical procedure, catheter-induced, NG, other tubic, IV line infections, they are all comes in the mind of a category of nosocomial infections. So let's look at next important I show early in the after infections. Next category is a malignancy, which has caused for 20% of cases of malignancy. is come in the category of PUO. Important malignancies are hematological malignancies, lymphoma, leukemias, and myelomas, or causes of PUO, which and other solid tumor of renal, kidneys, colon, and stomach. They are important malignancies. Other connectivity disorders, um, especially in females. Patient, a young female with who can't be able to diagnose which is the infection or which is the cause of the PUO. Think about the connective tissue disorders such as SLE, rheumatoid arthritis, temporal arthritis, and polymyalgia rheumatica. This is important causes of connective tissue disorder. And if a young adult male comes with a history of joint pain and salmon color rash, as I asked in the MCQs and the last paper of rheumatology, and most of you are unable to correct it. Salmon color rash is a specific for still disease, and still disease is always a favorite topic of examiners. SLE, whether see, in female SLE is very common, but never underestimate SLE in a male. There is some percentage of SLE in male is also there. Vasculitic disorders, yes. This category, vasculitis, always take history of in vasculitis, take three point in history. First, ask for joint pain, ask for any rash, and ask for any bleeding from any side of the body. This is a three typical critical point which you have to always ask from the patient. Joint pain. Number two, have a rash over body. Number three, bleeding from any side. This is if any one of three is positive, always think about patient may have a vascular disorder. The other connective disorders are poliomyelitis and fasciitis are also vasculitic. Other causes which we easily miss in PUO causes are atrial myxoma. If you listen a patient of a mid-diastolic murmur over heart, and there are two causes. The patient have a mitral stenosis or other patient have an atrial myxoma. Aortitis, aortic disease, and respiratory causes sarcoidosis, pulmonary embolism, thromboembolic disease, and some extensive allergic alveolitis can cause a fever which may last for a few weeks or a few even 4 months. So gastrointestinal causes, IBD is a very important cause of PUO, and a patient present with diarrheal illnesses and have a fever, spike of fever. So keep in mind is IBD is the number one differential of gut in the gut diseases. Other patient have alcoholic or pancreatitis, this, as I discussed earlier in detail. As few causes of metabolic or endocrine causes, thyrotoxicosis. Patient may have a thyroiditis and patient may have a spike of fever. So in general case examination of patient with PU, always examine thyroid. In palpate over, not even only see the patient have a goiter or not. Always make a habit of palpating the thyroid. Always go same palpate. Inspection, palpation, and Auscultation. These are rules always raise. These always remain same all examination. Listen or brew over third. And other are hypothalamic and pituitary diseases, endocrine, adrenal. These are all the causes which come in, means endocrine metabolic causes of PUO. There are hematological, hemolytic anemias. Always go for CBC where you can see anemia, and then MCV, MCH, retic counts. Patient have a high retic count. Think about the patient have an hemolysis over there, and or always make an habit of peripheral smear where you can see lytic cells and normal cells over there. PNH, thrombotic purpura, and myeloproliferative disorders. They are all come in the causes of hematological causes of PUO. Castleman disease, graft versus host infection, and this is a rare cause. Inherited, some young adult or have a familial causes such as familial Mediterranean fever and Brodick fever syndrome. These are rare causes and it's not so important. Yeah, this is a drug which I is very important. Even if patient have taking a habit of a multiple NSAIDs, or you are giving a patient a multiple dopamine or therapy of antibiotics, and patient have a fever. So drugs can cause a fever. Even NSAIDs, antibiotics, chemotherapeutic agents, biological agent, they are causing fevers. So always take a drug history when you suspect a case of PUO. Infectious fever, which young children have a habit of this fictitious fever. Idiopathic causes always be there for PUO. So, now with a few point in history, always when a patient I give you a history of fever, beside me I write a diagnosis, I write a formula for you is a OD bar. Onset, duration, progression, association, leaving factor, and aggravating power. When you this formula is write on your history sheet and ask question about onset, duration, which onset of patient first notice their fever, and fixed duration, how much time patient is suffering from fever. Progression is fever is step-ladder pattern, or patient have a start with a spike fever and then it's gradually down. So progression of the fever is very important. And then precipitating factor is patient fever is precipitating with any drugs, any environmental factors, any occupational factors. Take a proper history and living is if a patient is living with drugs, such a very important Pakistan national drug is paracetamol, which always patient take for fever. But this is a very dangerous drug as well. Associated factors. Always ask for associated feature of with fever. If patient have malaise, nausea, vomiting, which give you a clue. If patient have nausea, vomiting, you think about patient may have a gut infection, patient may have a biliary tract infection, patient may have hepatitis, patient may have a IBD, or patient may have a gastritis. Patient may, if patient have give you a history of night sweat, think about TB, think about malignancy, especially hematological malignancy, lymphoma, where the patient have a so sweaty night, even his bed is totally wet in the morning, and patient may have fatigue, arthralgia, arthritis, and cough. These are diarrhea. These are the all associated feature which you have to ask a patient when they present with a fever. Same as Riger's fever with chill and Riger. They are always the three differentials. Number one is malaria. Number two is UTI. Number three is sepsis. Anywhere when a patient present with fever and with chill and Riger, always we have a three differential: malaria, UTI, and abscess anywhere in the body. Weight loss. A patient has significant weight loss. Think about malignant disorders or a very serious infection such as HIV, TB, causes significant weight loss there. And pain is always a very helpful and a plus feature for doctors to clarify and to make a diagnosis. If patient say have a fever with abdominal pain, think about abdominal causes. Fever with pain in joint, think about connective tissue or rheumatological disorders. Any swelling, abscess, soft tissue. If patient have a lymphadenopathy, think about viral infections such as Epstein-Barr virus infections, mononucleosis, tuberculosis, even leishmaniasis and sarcoidosis. And these are the there's a lot of lists for lymphadenopathy, which you will see, and hopefully you will know all the causes of lymphadenopathy. But always remember five important causes here in Pakistan for lymphadenopathy. Number one, TB. Number two, malignancies such as lymphomas. Number three, viral infections such as HIV, Epstein-Barr, and cytomegalovirus. And number four, leishmaniasis. Number five, they are sarcoidosis, causes a massive lymphadenopathy. Skin changes. As I told you, vasculitis and many infections, you find a rash, and rash is always a very significant and characteristic for any infection, such as patient may have erythema migraine, which over arms, you easily differentiate, diagnose this patient suffering from Lyme disease, or the patient have a hot spot or rash, and you go for enteric fever. Or, the patient have erythema nodosum, think about sarcoidosis. So rash, patient have a morbilliform like rash, think about dengue fever. So rash, always examine when you do. We student always miss in general physics examination for skin examination. They go for nail, arm, tremor, BP, temperature, pulse, thyroid, anemia, jaundice, and but edema, and but they miss in examination. So in general physical examination, always make patient take habit of shirt, of your shirt, and then examine thoroughly to the patient skin. Skin is the largest organ of the body, as we. So previous history of fever is important. This is the same as I told in detail. So history of local exposure, such as in occupational history. The patient have skin connect with metals, heavy metal exposures, or patient consume of food or water consumption. In gut infections, always take few point in history of social history and history of habits, food and water, food and water, food and water. It's very important for find a cause of gut infections. Recent injuries, you may have a history of recent injury of leg. You know there is a small ulcer over there, but underlying bone is involved and patient have a 12 osteomyelitis and patient present with you with a fever from 4 weeks. So recent injuries is always an important contact with animals, birds and pets. This all come in your habits, history. Take this history very deeply. Sexual activities, patient travel to high risk areas and may got STDs. So STD is another important factor in comes in the entry of infections which causes the PUO. And most of the patient is don't that easily to give a sexual history to the doctor until to ask very privacy and the need tattoo or basic history is important to them. So this travel history I told in detail of everything. Question patient are either living in a rural or urban areas. A departure or return from outside of country, chemoprophylaxis, either malaria or chemoprophylaxis for malaria and other infections, vaccination. So all come in the same. As I told, this for autoimmune diseases always take a history of giant, rash, and bleeding. Same. Morning stiffness. So you see in a few diseases such as polymyalgia rheumatica and of course rheumatoid arthritis. Dryness of mouth in the rheumatological, if a patient have think about rheumatological Sjogren syndrome associated with SLE or RA, rheumatoid arthritis, red eye, dry cough, progressive shortness of breath, and so malignant disorders, digestive, night sweat, weight loss, and fatigue. Same definition I told in detail for everything. And if you have question, you can ask at the end of this session. Change in bowel habits, hemoptysis, hematuria, bleeding from any side of the body, enlarged. One is important factor you always ask from the history is either is direct question to the answer. भाई आपको किसी जगह पे कोई गिल्टियाँ तो नहीं जिसम में बनी हुई, गले में बगल में किसी जगह पे गिल्टियाँ तो नहीं है, किसी पे जिसम पे कोई नीले पीले निशान तो नहीं पड़ जाते. These are the few questions which you two line question. जिसम में किसी जगह पे गिल्टियाँ तो नहीं बनी हुई, किसी जगह पे बाजुओं पे इधर इधर एंड कोई जिसम पे नीले पीले निशान तो नहीं पड़े हुए. These are the two questions you easily rule out the hematological. जोड़ों में कोई हाथों के जोड़ों में इस जगह में कोई दर्द तो नहीं. The rheumatological screening is done. So that's it. So history taking is a very important technique, and when you go to a patient, you have a pre-planned questions in your mind for every system. So when you make a history or make a 3-4 question of every system and make a habit of asking from your friend or ask from every patient. Even if you diagnose this patient have a 3 days history of fever with associated with rigor and chill and rigor and with fever is a recurrent relapsing fever. Early to we make a diagnosis of malaria, but take a proper history of every system. This should be your habit. Same repetition. Sorry, family history. Some important malignancies, some leukemias, lymphomas. They are in solid, even some solid or organ malignancies, ovarian cancer. They run in families. Autoimmune disorders such as IBD and rheumatoid arthritis. Take a proper family history. Family history of tuberculosis is very important. So this is I make another sign and PU examination when you on the base of history always you have a diagnosis in your mind. When you make a diagnosis on the base of history, if your diagnosis is PU, then you always go for CR rash, petechial rash is so due to a vasculitic or sporic rash, histiocytosis, perennial rash, this is Kawasaki disease, pallor, jaundice, soft tissue, hyperthyroidism, spare eyebrows, ectodermal dysplasias, hair loss, oral ulcer, joint pain, SLE, tick-borne infections, as I told, Lyme disease, erythema migraine, herpes simplex, oral inflammation, herpes simplex virus, and eye examination is examination of eye, especially in part 2 exam, FCPS part 2 exam. Eye examination is very important. Always examine the eyebrows, eyelashes, then conjunctiva, eyelid, grouping of eyelid, then see pupil, symmetry, asymmetry, conjunctival hemorrhage, and then at the end do a fundoscopy. Just take approximately 2 minutes to examination of eye, but never miss the eye examination. Palpable or conjunctival bulbar erythema injection, SLE, tularemia, histoplasmosis, chlamydial infections, they all causes eye involvement. And then pupillary constriction, if there is no response to light, then think about dysautonomia and fungal lesion, toxoplasma, cytomegalovirus, spot spot, leptospiral. They all causes fungal lesions. And other diseases which causes eye involvement such as sarcoidosis, tuberculosis, toxoplasma, syphilis, steel disease, leptospira, they all causes eye lesions. Abdominal examination, liver, spleen is very important to make a differential on this basis of liver and splenomegaly, hepatomegaly. And muscular examination, musculoskeletal examination, joint swelling, there think about seronegative arthritis, IBD, Lyme disease, RA, connective tissue disorder, bony tenderness, osteomyelitis, see, lymph node, as I told you in detail. It's the causes of lymphadenopathy, autoimmune causes, cat scratch disease, cytomegalovirus, viral infection, epsilon or acute viral. These are just viral infection, bacterial infections, malignant disorders. They are all can cause generalized lymphadenopathy. Then lymphadenopathy is either localized, non-tender, or generalized lymphadenopathy. Cardiac findings, yes, infective pathology always come in if a patient with a younger children or a young adult come, think about with a murmur, fever with a murmur, think about infective endocarditis and rheumatic fever. There are two basic infective disorders which involve the heart. So investigation, there are investigation, you always go इन्वेस्टिगेशन के लिए तो उस वक्त ही जाओगे ना जब आप कोई भी चीज़ को पहले आप एक मेक है डायग्नोसिस आप बना लोगे अदरवाइज तो ईयू की इन्वेस्टिगेशन तो अप्रोक्सीमेटली 100 के राउंड होते हैं तो माइक्रोस्कोपी है so microscope blood for atypical lymphocytes blood for CBC and smears respiratory sample for mycobacterium and the fungus hyphae stool for ovacyst and parasites. So biopsy of all light microscopy, bacteria, fungus, urine examination, so, cultures, scent cultures for blood cultures, urine cultures, stool cultures, any joint aspirate cultures, and any pus. If you aspirate any pus from an abscess, scent cultures. Culture always identify a the organism. Culture can identify an organism and give you a susceptible antibiotic place to CSF cultures. Gastric aspirate cultures can be done. Stool, swab, urine cultures. These are all cultures. Then specific antigen detection, which is very important, such as an HIV antigen, HCV antigen, cryptococcal antigen by ELISA or by a screening test, aspergillus antigen. So antigen detecting even a urine for a Legionella antigen, CSF or cryptococcal antigen, nasopharyngeal aspirate, throat infection for and swab such as for the respiratory syncytial virus and for coronavirus infections and urine for Legionella antigen. So these are the first we discuss about the cultures, and then these are specific investigations. Then go for antigen detection, or and then ECR. Is very nucleic acid detection is very important in the cases of STDs. Blood for Bottonella virus species, PCR, CSF PCR for meningococcus, pneumococcus, listeria, and for herpes virus, nasopharyngeal aspirate for PCR for virus, sputum for mycobacterium tuberculosis, sputum examination, always send sputum for AFP in patient of AF PUO. This should be your first line priority. And if you are suspecting multi-drug resistant TB, go for gene expert and gene expert testing. From here, if you are suspecting pulmonary diseases, go for pulmonary alveolar lavage fluid and send fluid for histopathology and cultures, mycobacterium, virus, and fungus. Tissue specimens, such as for if your patient have a diarrhea and fever, and you take a state for but send for treponema weekly, and urine for chlamydia, trichomonas, especially if patient have a history of sexual contact, Ritter syndrome, and the gonococcal. These are the two important bugs for STD, chlamydia, and secondly is gonorrhea. Stool for rotavirus and novovirus, which is have a diarrhea, especially in children. These are other serological tests for HIV and interferon gamma assay for TB is an ORT, which is called quantitative TB gold rush. Is an standard screening test for tuberculosis. Then microscopy blood for trypanosoma and malarial parasite, slide, Borrelia stool, persistent parasite. The same additional testing, which is sometime is important in cases of connective tissue disorders, such as detection of ENA entries, RA factor, or anti-Smith antibodies, anti-centromere. These are some other, when you suspect a connective tissue disorder, go for that. Complement levels, immunoglobulins level. If patient have recurrent history of infections, recurrent fevers, go for immunoglobulin level. If the patient may have a hypoglobulinemia, congenital cause, or patient have a cryoglobulinemia, ferritin levels, CRP and ESR. These are the inflammatory markers and give you a estimation of severity of a disease. Echocardiography, if you find a murmur, or even echocardiography is comes in the early investigations of PUO. Ultrasound abdomen as echo and ultrasound abdomen. You find something over there, then go for CT or MI of thorax abdomen or pelvic. Images of skeleton, plain X-rays, CT, MRI, isotope scan, PET scanning for malignancy is very important. And if you suspect malignancy, but you didn't diagnose on the basis of your initial imaging, go for SPECT scanning, PET scanning with SPECT camera. PET scan give you a very good um, diagnosis of malignant disorders, bronchoscopy or lavage. And if the patient have a temporal artery biopsy, if you suspect polymyalgia rheumatica or temporal arteritis, go for temporal artery biopsy. So this is a final statement and prognosis of cases of PUO. No cause is found in approximately 10 to 15% of cases, but as long as there is no significant weight loss or sign of another disease, the long-term mortality is low in cases of PUO. Thank you very much for your listening, patient listening. And if you have any question, then type your in the chat box. I will answer. Thank you very much. I am giving you my email address. If you still have any query, you can ask me via email. Any question? Otherwise, I will ask questions. Any questions, students? Not listening to me? Tell me. No question? As I am the main person for your test. paper. I will ask this question in your exam. And please don't make habit of copy your paper. We'll check your paper. तो हर बंदे ने कट कॉपी पेस्ट किया होता है. This is not a good. Still no question.